Hello, my name is Katie Mark. I'm an associate professor in the Department of Obstetrics and Gynecology at the University of Maryland. And today, in this mini video, we're going to be discussing pregnancy and addiction. There are a lot of things that we could discuss relating to pregnancy and substance use disorders. But for this mini video, we're going to focus on how to discuss pregnancy with people who have substance use disorders and what first steps any provider can take when their patient becomes pregnant to optimize the health outcomes for all involved. Sometimes a patient will tell you that they're pregnant, but sometimes you will be the one disclosing this information to them when they have a positive pregnancy test. When disclosing a positive pregnancy test, it's very important to be completely clear, using statements such as, "Your pregnancy test is positive, which means that you are pregnant." This statement should be made in a very neutral tone, and the patient should be given time to process this information. It's very common for people to have mixed feelings, such as fear, uncertainty, or even ambivalence about becoming pregnant. No assumptions should be made about how a person will feel about being pregnant. For example, when disclosing a positive pregnancy test, saying congratulations is making an assumption. The reverse is also true. It should never be assumed that someone does not want to be pregnant just because they have a substance use disorder. Instead, giving them time to process the information and then asking a question that is open-ended, such as, "What thoughts and feelings are coming up for you right now?" is a much more non-judgmental and open way to approach the conversation. The Reproductive Health National Training Center have online training modules that teach providers how to provide non-directive options counseling when discussing pregnancy. It's important to have this conversation in a non-judgmental way because stigma is one of the most significant barriers to receiving prenatal care. Pregnant people report feeling fearful of their prenatal care providers finding out about their substance use because of their concerns about child custody, legal or criminal consequences, and stigma and discrimination. This leads to them hiding their use and engaging in social isolation, both of which increase the risk of fatal overdose. The most common strategy that people report using to avoid detection of drug use during pregnancy is actually just completely avoiding engaging in care. So what are the risks of drug use during pregnancy? The risks vary based on the drug itself and the individual circumstance, but they range from preterm birth and low birth weight to long-term behavioral and neurodevelopmental differences. It's important to remember that the legality of a substance does not equate to its safety. The two drugs that we have the most evidence of direct harm to in pregnancy are tobacco and alcohol, both of which are legal. Fetal alcohol syndrome is the leading preventable cause of birth defects and neurodevelopmental disorders. Alcohol use is a very under-recognized, screened for, and treated thing during pregnancy. It's important for providers to strike a balance between explaining the potential risks of drug use in pregnancy, but also not painting an overly bleak picture and implying that there's no hope for a healthy pregnancy. More than a quarter of people who decide to terminate their pregnancies report that at least part of their decision was related to their concerns about the effects of their drug use on their baby. Well, it's true that people who use drugs on whole have a higher risk of pregnancy complications. A large part of this is actually due to the behaviors that often surround drug use, such as malnutrition, stress, and other risky behaviors, as well as lack of prenatal care. When studies evaluating pregnancy outcomes adjust for psychological factors and adequacy of prenatal care, the risk of exposure to the drug itself seems to be somewhat mitigated. Studies have also shown that early intervention after birth for substance-exposed newborns can improve their outcomes long-term. So it should be stressed that engaging in regular prenatal care, substance use treatment, and early childhood intervention can improve the outcomes for the mom and baby. If someone desires to continue their pregnancy, there are a few key things that any provider can do to start the process of prenatal care. This includes recommending prenatal vitamins, ordering an ultrasound to assess the pregnancy, its location, the gestational age, and the viability of the pregnancy, and discussing the safety of any currently prescribed medications. If someone's uncertain about their plans for the pregnancy, taking these first few steps can help to improve the health of the pregnancy if they do decide to continue. Delaying starting prenatal care until someone is certain about their plans for the pregnancy can lead to missed opportunities to improve outcomes. Many medications that are used to treat substance use disorder can be continued during pregnancy. For example, for smoking cessation, nicotine itself And nicotine-containing products, such as nicotine replacement therapy, may have some risks in pregnancy, but weighed against the smoking of combustible cigarettes, they're generally considered to be harm reduction strategies. Varenicline is not well studied in humans, but data that does exist implies that there is no direct relation of harm to the pregnancy. Bupropion has not been linked to adverse pregnancy outcomes either, and is generally recommended during pregnancy. Medications that are commonly used for alcohol use disorder and opioid use disorder, such as acamprosate and naltrexone, have not been shown to be associated with any adverse pregnancy outcomes either. Disulfiram, however, has been linked to birth defects and should be avoided during pregnancy when possible. Topiramate exposure in the first trimester is potentially linked to increased risk of cleft lip and palate. Medications for opioid use disorder, including methadone, buprenorphine with and without naloxone, and opioid blockers such as naltrexone, have all been studied in pregnancy and are considered to be safe and effective. It's worth noting that the original studies evaluating the efficacy and safety of buprenorphine were done using the mono product, and this led to early recommendations that the mono product should be used in pregnancy. However, follow-up data have shown similar outcomes with buprenorphine plus naloxone products, so it's no longer recommended to switch to the mono product just because someone is pregnant. While some birth outcomes may be slightly statistically better with buprenorphine compared to methadone, the pregnant person should be encouraged to take whichever medication is the most effective for them and be given the choice between these different medications for opioid use disorder. It's very important to remember when discussing the risks of any medication in pregnancy that we should consider the risk in comparison to the risks of the alternative. In most cases, the alternative to prescribing these medications or taking these medications is continued substance use, which almost always has a higher risk to the pregnancy than the medication itself. Unfortunately, pregnant people are often excluded from medication trials. Paradoxically, this desire to protect pregnant people has led to a dearth of prospective data on many prescription drugs. However, it's rather counterintuitive to counsel a pregnant person that the risks of their substance use in pregnancy are concerning, but then also deny them access to treatment because of a lack of well-designed studies of these medications in pregnancy. A reasonable idea of risk of medications can often be determined based on their mechanism of action, preclinical data, retrospective studies, and birth registries. While pregnancy can be a motivating factor for many people in their recovery, providers should always provide person-centered care. This means that discussion should include how their substance use may affect their pregnancy, but also how pregnancy may affect their substance use. We should be careful not to give the message that someone should stop using drugs or decrease their use only because they're pregnant, but rather because it's important for their own health as well. Pregnancy can be used as a time to reevaluate overall health and behaviors. While abstinence is typically the healthiest option, it's not always possible. Pregnant people often feel immense guilt about their substance use, which can lead to loss of confidence in themselves and their recovery. Discussion of harm reduction steps, such as decreasing frequency and amount of use or switching use to a less risky route of administration, can help decrease the potential health consequences. Naloxone is approved for use in pregnancy and should be offered to anyone with opioid use disorder. It's the healthcare provider's right and ethical responsibility to disclose all options for a pregnancy with their patients. If a person decides that they do not want to continue their pregnancy, or even if they want to explore their options, they should be given medically accurate information and resources. There are several organizations that provide evidence-based information and can assist with access to medical care for those who are seeking abortion. Lastly, any pregnant person should be screened for intimate partner violence, even if they've screened negative in the past. Intimate partner violence is very prevalent in women with substance use disorders and even more prevalent during pregnancy. Pregnant people who have experienced intimate partner violence should be counseled about resources and have a safety plan. So in conclusion, pregnancy testing should be offered to those of reproductive potential, and the results should be discussed in a non-judgmental and comprehensive way, and all patients should be offered comprehensive options counseling. Substance use during pregnancy does have risks to both the mother and the neonate, but these risks can be largely mitigated by engagement in prenatal care and substance use treatment. And screening for intimate partner violence should be standard in all healthcare settings.